All right, so I'd like to start by just starting with a few examples. I was assigned to give a talk about spine tumors, and I just want to state that I am at Ohio State, but I've been taking a job at Yale University, so I'm going to be studying at Yale in the next month or so. So I'm going to talk about spine tumors, and I want to give a shout out to the fact that we do a dedicated spine tumor course once a year at the Seattle Science Foundation. And so I've given about 25 minutes to give a talk about whole spine tumors. I'm going to try and go pretty fast. So let's start with a few cases. This is a 57-year-old male with back pain who's been diagnosed with multiple myeloma. And where do I click to move the slides forward here? Okay. And what you can see here is that there is a patient here with multiple myeloma with a fracture at L2. This patient only has mechanical back pain. He has no neurological deficits. And I'm going to ask each one in the audience, how would you manage? This is the kind of typical patient that comes in either to the emergency room or to your clinic, has a known diagnosis of multiple myeloma with a fracture. How would you manage that particular patient? Next slide. All right, the next case is a 52-year-old patient, known diagnosis of metastatic renal cell carcinoma, who's presenting with the same problem, just back pain. So I'm trying to make it very straightforward in the sense that these are all patients who are coming in with similar MRI findings and similar complaints. This particular patient has a metastatic renal cell carcinoma. Let's look at the slides of this patient. What you can see here is another L1 mild pathologic fracture on a patient with metastatic carcinoma. How would you manage this patient? Would you do a corpectomy? Would you radiate this? Would you do a biopsy? Would you do a cement injection? What would you do here as compared to the other patient with multiple myeloma? This is a patient who's a 52-year-old who's coming with back pain, left leg pain, and a CT-guided biopsy revealed chondrosarcoma. So unlike the first two diagnoses, this is a primary bone tumor. This patient, again, is neurologically intact. And you can see right here, this is an L4 chondrosarcoma with back pain and some radicular pain symptomatology. How would you manage that? And then the next patient, go to the next slide. Here is a fourth case, a 68-year-old with metastatic thymic carcinoma. And you can see right here, T11, T12 have metastatic disease there with maybe a mild pathologic fracture of T11. The presentation is the same. These are all thoracolumbar metastases. How would you manage this patient? So the question that I have for you all is, do all these patients require surgery? Does the different type of cancers makes any difference? And would the approach be similar to all of these cases? So we're looking at 4 or 5 cases. They're all presented with similar findings of back pain. They all have about thoracolumbar metastases. And the question is tumor biology really makes any difference here? So what are the management options that we have? We have an intralesional option where we're going in and we do a vertebrectomy, we drill it, we take the vertebrae out, we reconstruct it. We have an option from surgery of do what we call an en bloc resection, where we get around the tumor, we take it all in one piece, we don't get into the tumor. We try to keep clear margins to try and minimize spillage of tumor into the surrounding. We have an option of stereotactic radiosurgery, we have options of radiation, chemotherapy, and then we have an option of minimally invasive of vertebroplasty or a kyphoplasty with cement injection into those vertebral bodies. Next slide. So I want to start with, I started with 5 cases where I showed you 5 different cases of patients with different metastases, but I now want to go into a situation that gets to be a little bit more complicated. And that is what happened when patients come in with cancer with neurological issues. And let's start with this one. This is a 23-year-old who's coming in with 1-month history of back pain. On the day of presentation, she stood from her desk and had severe back pain and some weakness, could not get out. And she was brought to the emergency room, and you get called to see her in the emergency room. Next slide. And on exam, she has mild weakness in her hip flexion. Otherwise, she's 5 out of 5. She has a sensory level at T12. Her reflexes are normal. And what you see here is a T9 vertebra broken. There's severe canal compromise from something compressing the spinal cord. And this is sometimes the typical scenario that each one of you can find yourself in, where you cover an emergency room, you get called, somebody comes in with mild weakness in the legs, and this is what you find. And the disadvantage here is that you don't know what you're dealing with. You don't even know if it's cancer. It definitely looks like cancer, but there's no diagnosis on a patient who has very mild weakness in the legs. And the question is, each one of you, if I was there to talk to you, I would ask you, what would you do here? Would you take this patient to surgery? Would you wait? Would you put the patient on steroid? Would you be willing to wait on this? And next slide. You can see more cuts here, next slide. And you can see right here that the tumor is not just in the canal, but it's wrapping around the entire vertebra. Next slide. You can see that there's a little lytic lesion there. There's mild pathologic fracture. Next slide. And the patient ultimately was taken by the neurosurgeon on call for an emergent laminectomy. And you can see after the surgery, a wide laminectomy was done. Decompression of the thecal sac was done. Next slide. You can see this is what the MRI looks like after the surgery. And you can see the spinal cord has been decompressed. The pain got better, the weakness got better, but the intraoperative pathology came back as lymphoma. And so the question is, whether this patient really needed surgery, because lymphoma is a very radiosensitive, chemosensitive tumor, and whether there was a role to wait and not take this patient to surgery and maybe do the biopsy first, because if we were to know that this was a lymphoma, this is a patient who likely would have done very well with adjuvant therapy, not necessarily surgery. And next slide. Let's take the same case, for example, and this patient is not just having mild weakness in her legs, maybe like before, 4 out of 5 strands, but now she's coming in, same case, same MRI findings, but the weakness is severe, 2 out of 5 strands in the leg with a sensory level at T12. Would you then be more inclined to take this patient to surgery or not? And that's why I want to bring this point to, we have to make a call in the emergency room where what kind of deficits we are willing to accept in order to make the diagnosis and figure out whether surgery is indicated or not, or whether the deficit is significant enough to the point that we as a surgeon getting called at night to take care of this patient are unwilling to wait and take this patient to surgery. How much of a deficit is a lot of deficits and how much of a deficit is not a lot of deficit that we're willing to wait on? Next slide. Here is another case of a 51-year-old with severe back pain who comes in with 1 week progressive foot weakness, intermittent bowel bladder function. Next slide. And you can see right here that the S1 vertebrae is broken. There is severe canal stenosis in the sacral spine. The sacral canal is full of tumor. And what you can see here is that there is something going on at S1. Again, this patient, unlike the other patients, coming in with severe neurological deficit with weakness and bowel bladder issue for a week. And the MRI shows severe compromise of the sacral nerve roots. Would you take this patient to surgery at night to decompress the thecal sac, or would you wait? And the patient underwent an intralesional debulking, a lumbo-pelvic fixation. The biopsy, unfortunately, came back as a primary bone tumor with a chondrosarcoma. The patient's symptoms got better for a period of time. This was once found to be a chondrosarcoma, was followed with stereotactic radiosurgery 6 weeks after the surgery. And clearly, the patient had done well because the sac has been decompressed. The bowel bladder function came back, the pain went away, and he has done very well for about a few years. And then came back, next slide, and noticed that there's a little bump in the back of his back, and the patient thought that one of his screws was getting loose and start poking out to his back. Next slide. And unfortunately, what you can see, as we expected, is that the red arrow is pointing to a recurrence of tumor consistent with chondrosarcoma, and there's significant recurrence in the operative side. So what happened here is a primary bone tumor that may have been benefit from unblocked resection without intralesional decompression in order to minimize recurrence, ended up getting through with the decompression of the thecal sac with temporary relief of the symptoms, but only for it to recur several years later. And now this is not a curable disease. And not only that, but there's no fusion there. The rod is broken. And what you can see here is that we ended up taking that recurrence out through an en-bloc fashion, getting all the way around it, and then actually had to have plastic surgery to come by and decompress it, and in essence, revise the rod, and after that follow with a large flap to close this wound. So that's unfortunately what happened once you start doing an intralesional resections on patients who have primary tumors. So the take-home point is that sometimes mismanagement is related to bad timing of operation, of when to do the surgery, or operation with no diagnosis, where you really don't know what's going on. And so be aware of the triple W that I call, with the wrong operation on the wrong patient by the wrong surgeon. And so I kind of wanted to show you all these cases because this is really what we are faced with. And unlike maybe a herniated lumbar disc or stenosis, where you know that the idea is about decompression and fusion, you're dealing with patients with cancer, and every different case of cancer with different pathology require different planning. And so you really have to be a good oncologist in addition to a good spine surgeon to figure out how to manage these patients. And then on top of all that, you're dealing with the patient as a whole. So a lot of these patients are immunocompromised with a high risk of postoperative infection related to chemotherapy, bad infection with Pseudomonas, lack of fever response. Sometimes they get cement injection with the cements get infected. They're nutritionally commonly depleted with significant weight loss, and you can find that with the serum albumin. Sometimes you find out that they are on steroids related to the chemotherapy that lead to all kind of other significant problems, as listed here, with significant morbidity, myopathy, psychosis, osteoporosis, on and on and on. And coagulopathies also. A lot of these patients who may need surgery, they're presenting with thrombocytopenia, with low platelet count. And how are you going to manage that? They are presenting, and there always tends to be with increased risk for DVTs. And so you have to think about all those things as you're planning on doing surgeries for these patients. And a lot of times, if you take patients to surgery without a diagnosis, you may end up operating on a very vascular tumor, and you find yourself in a bloodbath related to significant amount of bleeding during the surgery. So one of the advantages to know what you're operating on is, to know what type of tumor that is. And these are the vascular tumors that need preoperative embolization. As you all know, the renal cells, the hepatocellular carcinomas, the follicular thyroid, the pheochromocytomas, these are all very vascular tumors that require preoperative embolization. And then, I don't want to get into it, that's a separate discussion, but sometimes through this embolization, you end up finding where the artery of Adamkowitz. And if that is the case, and it's right at the area where you're planning on operating, how are you going to manage it now that you know that it's there? So there's a whole set of different issues. And one of the biggest one is really wound management, as I just showed in the last case, where a lot of these patients are increased in age, they've altered immune system, and plastic surgeons become good friends of yours when it comes to managing of these patients. A lot of them has been radiated before. The cervicothoracic incisions are notoriously tends to open up. So again, I think that plastic surgery is key in a lot of these cases, which again puts the emphasis of knowing what you're operating on before you do these cases. This is some of these cases on patients with bad sarcomas. And clearly you can go in and do surgeries for a lot of these sarcoma patients and do en-bloc resections. And this is a patient with involvement of the posterior elements. They require massive surgeries, removing all of these huge tumors that are infiltrating the muscles and the posterior elements. And ultimately, you're going to need your plastic surgeons colleagues to be able to close these wounds. This is after a case of sacrectomy. And again, a lot of planning goes into these cases when it comes to not just doing the surgery, but actually wound closure. So the surgical planning is key. You want to know what's your purpose of diagnosis of a surgery, whether you're planning on trying to cure these patients or palliating it, whether you're going to do an en-bloc resection or intralesional resection. You got to figure out how to instrument it from a biomechanical consideration, what's the wound status, and overall, what's the medical status of this patient. And so as you look at that, you have to figure out whether you're dealing with a primary or metastatic disease. Clearly, I want to emphasize that the histology is very critical. That would tell you everything about what you need to know about the biologic behavior, the metastatic potential. And ultimately, what you want to do when you do this biopsy is figure out ultimately that you want to do this biopsy upfront before, if you have the time to do it. This is a case on a patient who was diagnosed with presumed chondrosarcoma, which was scheduled to have an unblocked sacrectomy, but a biopsy revealed that this was actually a very large ependymoma that does not require a sacrectomy. So clearly, sometimes one thing looks one thing, and a biopsy shows that it's completely something else. So the biopsy is very critical. Just make sure to avoid the transoral or the transrectal biopsies. This is a chordoma of the cervical spine and chordoma of the sacral spine. If you do a transoral or a transrectal biopsy, you won't be able to remove the tract with the specimen, and so you have a higher chance of recurrence through the tract itself. And clearly, if you go through a biopsy through the mouth or through the rectum, you're not going to be able to remove that tract with the specimen. So here is an example where we did a sacrectomy, and you want to mark where the site of the biopsy is done, and then you can move the flap around the biopsy tract itself, and doing the sacrectomy to include the tract itself to minimize the chance of recurrence. And this is another case of a complete sacrectomy where we leave the biopsy tract alone, including the skin, and then when the sacrectomy is done, the skin, the tract itself, is being removed with the sacrum itself. So this is a bad biopsy, right? It goes way off from the side. Make sure that you instruct the biopsy interventionalist to do the biopsy close to the midline. The closer it is to the midline, the easier it would be for you to then be able to remove that tract with it. Reconstructions for these cases are very critical. And you're going to learn to do a lot of these reconstructions. There's a lot of talks about carbon fiber that is another talk for itself. You can see what happened with a lot of reconstructions that we do where there's a lot of artifact that goes along with these cases. And I'm going to talk into that in a few minutes. So when it comes to management, I want to also talk about radiosurgery. Any spine cancer surgery, when you do these cases, radiosurgery is a critical portion of what we do, especially for situations where we have radiosensitive tumor, stable neurological exam, patients with limited life expectancy, or patients who are unable to tolerate the surgery. It is an amazing technology. It is help us to really take care of a lot of these patients who are potentially unable to go to surgery or don't need surgery. Here's a patient with a solitary met who has some back pain. This patient does not need a vertebrectomy. Radiosurgery would be a very good indication for it. Here is a patient who has a recurrence with tumor wrapping around the vertebral artery. There's no need to go after that. This is a very good candidate for post-operative radiosurgery on these patients. So overall, radiosurgery is totally non-invasive. It's really working very well for newly diagnosed solitary mets, and post-operative treatment for high-risk recurrence works very well for this patient. The third option that I mentioned is cement injection. I'm just going to go through this very fast. Those who are proponent of vertebroplasties or kyphoplasties, there's not a lot of difference when it comes to the outcome for these patients, and when it comes to ultimately helping them with the significant amount of pain that they have. Done a lot of comprehensive reviews on that, and it is a huge tool to be able to do these type of cases on patients who are very sick, who have a lot of back pain. There is contraindications to do it. Some of those contraindications related to the amount of fracture, the amount of canal compromise, breakage of the posterior elements with a worry for leakage of cement through the back. You can see right here, the back wall is missing. There's a risk that as you inject cement, some of that cement with no posterior wall can leak into the canal. And so we looked at some of those quote contraindications, and these are the things that you want to avoid with, you can see right here with the cement leaking through the back of the canal, compromising the exiting nerve root. You can see right here, a vertebroplasty with cement in the canal, all wrapping around the thecal sac. Sometimes you can see cement in multiple areas in the lung, or sometimes you even see dots of cement in the brain. So it's not a benign procedure. Here's one of those cases, again, with cement injected into the vertebral body, but ended up finding itself into the canal. So it is a straightforward procedure, but there is potential for issues with that. Here's a patient that we pushed the limits with actually doing a transoral vertebroplasty that saved these patients an occipital cervical fixation. So I think that the cement aspect is a very good tool that you can have, and some of those contraindications can be refuted. And you got to really analyze a lot of these case by case as to who are the candidates who are not. But we find out that a lot of patients who have severe back pain, who have very short lifetime expectancy, some of those contraindications can be relaxed in order to help these patients. And this is, again, one of those cases where this is a very sick patient who ended up going through transoral cement injections. The fourth option is the unblocked resection that I mentioned for primary bone tumors. These are cases where we try to stay away from getting into the tumor. You got to do a lot of planning on these cases and be able to remove ultimately these patients these tumors in one piece. So overall, in summary, I would say that the indication for surgical treatment is these 4 criteria that I like to always use. 1, you want to do these surgeries if you think that you can change the prognosis. 2, you want to do these cases if you need to fix spinal instability. 3, you want to deal with a neurological compromise. And pain is an indication by itself to help patients with cancer who has significant amount of pain. I'm just going to skip these for the sake of time.
Thanks, Udi. I think we're a little over. One final take-home message.
Yeah, so I would say that if we summarize the management of spine tumors, I think if you take one message point, it would be the diagnosis is very critical to make sure that you know what you're operating on, because that ultimately will allow us to establish our further management options for these patients. Thanks, Charlie.
Yeah, thank you so much. I think that's key to really the histology plays a critical role and really dictates the management.